Hi, this is Sarah, and we're going to talk about Chapter 22, which is the Eating Disorder chapter. Here are the objectives for this chapter. Now, just as a little introduction to human appetite and regulation, the hypothalamus is the part of the brain that contains the appetite regulation center, and it regulates the body's ability to recognize when it's hungry and after somebody has eaten, when it is sated. Now, eating behaviors are influenced by, sometimes they're physiological changes, and sometimes they're influenced by both society and culture. And historically, society and culture have also influenced what it is considered to be desirable in the female body. And most eating disorders are found within the female population. Now, there are some segments of the male population that are also prone to eating disorders, but by and large, it is a disorder of females. Now, epidemiological factors. The prevalence rate of anorexia nervosa among young women in the U.S. is approximately 1%. Anorexia nervosa occurs predominantly in females ages 12 to 13 years. Now, bulimia nervosa is more prevalent than anorexia nervosa, with estimates of up to 4% of young women having bulimia. Onset of bulimia nervosa occurs usually in late adolescence or early adulthood. And obesity has been defined as a body mass index of 30 or greater, and 68.5% of the adult Americans are overweight, and 35% of these are within the obese range. So, assessment. What do you do when you are assessing someone and you want to assess for eating disorders? First, you want to look at what are the thoughts and behavior, with regards to anorexia nervosa, you want to look at what the thoughts and behaviors associated with anorexia nervosa are. Do they have a terror of gaining weight? Are they preoccupied with thoughts of food? Do they view themselves as fat even when they're emaciated? Do they have peculiar handling rituals with food? Do they cut their food into very, very, very small bites, and do they push the pieces of food around on the plate, but they don't actually eat any of the food? Some possible other possible developments is they might have a very, very rigorous exercise regime. Now, exercise is good, an hour a day is a good thing. People who exercise as part of an eating disorder, they'll exercise for 8 or 10 hours a day, and so that definitely will affect their lifestyle and their health. They might have possible self-induced vomiting and the use of laxatives or diuretics, and their cognition might be so disturbed that the individual actually judges their self-worth by his or her weight. So, for instance, if the less they weigh, the more they feel worthy of themselves. Some signs and symptoms of anorexia nervosa specifically: low weight, severe caloric restrictions or excessive exercising. Sometimes, like somebody who has anorexia nervosa, they might eat a cup of popcorn for breakfast and a cup of popcorn for lunch, and then 2 cups of popcorn for dinner, and that is all they eat throughout the day. And so that would be a severe caloric restriction. Or the excessive exercising that we talked about earlier. Amenorrhea, which is absence of menses, and this happens whenever your weight goes below a certain threshold. They might have some hyperkeratoemia, which is yellowing of the skin. They might have some lanugo, which is that fine downy hairs on the face and back, and this is a sign of starvation. They might have cold extremities. This is another a sign of starvation. They might have some peripheral edema, so their feet and calves and ankles and hands swell. And the reason for this is because when they starve themselves, they go into a hypoalbuminemia state, and so their protein levels get all messed up. And so and so you have the fluid shifts related to low protein levels. And then they can also have swelling as a part of refeeding syndrome. And refeeding syndrome is a metabolic disturbance secondary to eating regular food after periods of starvation. You can have refeeding syndrome with populations that are actually starving, like those that are in poverty-stricken third world countries, or when you have somebody who is intentionally starving themselves, like with somebody who's anorexic, and then they eat regular food. They may also be thrown into this refeeding syndrome. Muscle weakening is another sign of anorexia, and this is due to starvation and electrolyte imbalances. Constipation due to starvation. They can have cardiac abnormalities, and this is due to the electrolyte imbalances and dehydration that come with starvation. Impaired renal function, and then you also want to ask them how they view their situation. You might have a young woman who is, let's say she's 16 years old and she weighs 80 pounds, which for let's say she's 5'6". So for a human who is 5'6", weighing 80 pounds is very much under what would be considered a normal weight for her. But then you ask, so what do you think about your weight? And they may say, well, I think I'm fat. I think I could stand to lose a couple more pounds. And they really may or may not have any insight into their illness. Now, signs and symptoms of bulimia nervosa. Bulimia nervosa is the episodic, uncontrolled, compulsive, rapid ingestion of huge quantities of food over a very short period of time. And this is called binging. So when we're talking about someone who's binging, we're talking about they will eat 3 packages of potato chips and 2 gallons of ice cream and finish it off with a liter of soda all at once, within 30 minutes. That's what we're talking about by binging. And then after they've binged, they immediately or very shortly follow by a compensatory behavior to rid the body of the excess calories. So they'll induce vomiting, or they'll take a bunch of laxatives and give themselves really bad diarrhea, take some diuretics to pee off the fluid, or give themselves some enemas. So basically they've taken in this huge amount of food, and now they want to get rid of it in some way, and usually that's either through self-induced vomiting or use of laxatives and enemas. Fasting or excessive exercise may also occur with those who have bulimia nervosa. Most individuals with bulimia are within a normal weight range. Some are slightly underweight and some are slightly overweight, but with bulimia you don't tend to have people who are really, really, really emaciated. Excessive vomiting and laxative or diuretic abuse may lead to problems with dehydration and electrolyte imbalances. And the electrolyte imbalances, in particular the imbalance of potassium, is what gives them cardiac abnormalities and heart attacks. Depression and anxiety and substance abuse are common with people who have eating disorders. So predisposing factors. They don't know why exactly one person gets an eating disorder and another person doesn't, but they think that biological influences play a part. Genetics may play a part. There seems to be a hereditary predisposition to eating disorders, and this has been hypothesized. Anorexia nervosa is more common among sisters and mothers of those with a disorder than among the general population. There might be some neuroendocrine abnormalities. Some studies have studied that there's dysfunction in the primary hypothalamic system in those who have anorexia nervosa. There might be some neurochemical influences. The neurotransmitter serotonin and norepinephrine may be involved in the predisposition to bulimia nervosa, while high levels of endogenous opioids might be associated with anorexia nervosa. There might be some psychodynamic influences, and these theories suggest that eating disorders result from early and profound disturbances in childhood that result in delayed development of the person. There might be family influences, in particular conflict avoidance. Some families may promote and maintain these psychosomatic symptoms, including anorexia nervosa, in an effort to avoid conflict within the family. And so basically what this is saying is you have two parents who fight all the time, and so the child who has anorexia becomes the problem, and so the focus is focused on the sick child rather than focusing on the two parents that are fighting. They think that there may be also elements of power and control. Power and control may become the overriding elements in the family in the client that has an eating disorder. Parental criticism promotes an increase in obsessive and perfectionistic behavior on the part of the child. And the child is trying to seek love and approval and recognition, but in this family dynamic, they think that the parental criticism is making that not possible. And so a lot of power and control issues tend to come up when you're working with people who have eating disorders, because with a lot of people, sometimes the only piece of power they have in their lives is what food they put in their mouths. Everything else is completely planned out for them by either parents or schools or coaches or what have you. And so in an effort to regain power, they can sometimes they feel that the last thing they have control over is, I'm going to eat that or I'm not going to eat that. And there you go. So the power and control definitely seems to be playing a part. And then environmental factors also seem to be playing a part. Now, there are cultural norms, especially within Western society, to be thin and to look like supermodels. And the thing about supermodels is that only 1% of the population looks like a supermodel. So it's almost impossible for regular, everyday people to attain that. But people still strive for it. So. Okay, so assessment of obesity, binge eating disorder, and other predisposing factors. Now, with obesity, a body mass index of 30 or greater is considered obese. Now, at this level, or BMI, weight alone can contribute to increases in morbidity and mortality. Obese people are at higher risk for hyperlipidemia, diabetes, osteoarthritis, angina, and respiratory insufficiency. Now, the DSM-5 identifies binge eating disorder as an eating disorder that can lead to obesity. And in binge eating disorder, the individual binges on large amounts of food, like with bulimia nervosa. But the difference with binge eating disorder is that the individual doesn't engage in those behaviors that rid the body of the excess calories. So with binge eating disorder and obesity stemming from binge eating disorder, these people are still eating 3 packs of chips, a liter of soda, and 2 pints of ice cream in one sitting, but they're not making themselves throw up, or they're not taking laxatives to rid themselves from the extra calories. Now, some predisposing factors to obesity and binge eating disorders. Genetics seems to play a role. 80% of children born of 2 obese parents will also be obese, and twin studies have also supported a hereditary factor. Physiological lesions that contribute, they seem to find sometimes that lesions have been found in the appetite and satiety centers in the hypothalamus. Hypothyroidism may play a role. Decreased insulin production may play a role. Increased cortisone production, as seen with stress situations, may play a role. Increased caloric intake, obviously, and then sedentary lifestyle is also going to play a huge role. Okay, so the nursing process. Nursing diagnosis are going to be imbalanced nutrition, either less than body requirements related to a refusal to eat, or more than required with those who binge eat. They might also have deficient fluid volume, ineffective denial, imbalanced nutrition more than body requirements, disturbed body image or low self-esteem, and anxiety, either moderate to severe, related to feelings of helplessness and lack of control over life events. Now, the outcome criteria are identified for measuring the effectiveness of nursing care, just like with any other nursing process. Now, with eating disorders, we're going to look at, has the client achieved and maintained at least 80% of the expected body weight? Are there vital signs, blood pressure, and lab studies within normal limits? And have they verbalized the importance of adequate nutrition? The client also, another outcome is, do they verbalize the knowledge regarding consequences of the fluid loss and electrolyte imbalances by self-induced vomiting or laxative abuse, and also the importance of adequate fluid intake? And are they able to verbalize events that precipitate their anxiety? for those who use eating, what they eating and how much food they put in their mouth as a coping mechanism for anxiety and stress. The client, are they able to verbalize ways in which they can gain more control over their environment and so reduce their feelings of powerlessness? And then are they able to express the interest in the welfare of others and less preoccupation with their own appearance? And then finally, are they able to verbalize that their previous perception of their body, of their image of their own body as being fat was a misperception? Are they able to understand or accept that how they saw themselves before was a misperception to how thin and how underweight they actually were? Now, the client with obesity, are they able to establish a healthy pattern for eating and weight control, exercising, portion control, etc., and so forth? Are they able to verbalize plans both for future maintenance of weight control and also to not binge eat? Teaching this population what a normal portion size, and that yes, you can order a pizza, but you can't eat the whole pizza all at once, is a huge thing. So planning and implementation. Immediately, if you have somebody who is medically unstable, the immediate concern is medical stabilization, and this is in particular for those who are less than 75% of their ideal body weight, or if they have extreme electrolyte imbalances. So basically, you get them medically stable before you go into these other issues. And then you want to carefully reintroduce food to avoid refeeding syndrome. Nursing care of the client with an eating disorder is aimed at restoring nutritional balance. And emphasis is also placed on helping the client gain control over their life situation in ways that in ways that are not inappropriate eating behaviors. And self-esteem and positive self-image are promoted in ways that relate to aspects other than appearance. Now, no man is an island and no patient is an island, especially with eating disorders. And so oftentimes there has to be a lot of family, both client education and family education, because once they leave your facility, they're going to go into their family dynamic, and their family dynamic has to accept and help the client manage their eating disorder and the recovery from the eating disorder. And so the goal is to help the family and the person learn how to normalize eating patterns and address the medical, family, and social issues. Precise meal times often are very, very important. Adherence to a selected menu. If you're having chicken and broccoli and rice in normal portions, it's not in the family dynamic, you need to stress that it's unacceptable for the person who has anorexia to say, oh, that's great, I'll have one little bite of chicken, and then I'm going to have air pop popcorn, and that's going to be my dinner. So adherence to the selected menu is very, very important. Observation of the client during and after meals, and especially trips to the bathroom right after eating, because somebody who they may sit at the table and eat all their meal, but then if they go to the bathroom and throw it right up, then that's not healthful behavior. And then regular scheduled weighing, and this may be once a week or once every 2 weeks or once a month, but no sooner. One of the signs of obsessive thoughts about weight is compulsive weighing, and some people might weigh themselves 6 to 10 times a day. So we want to teach them, no, you can weigh yourself, but you can only weigh yourself once a month. Family therapy is very important. The family is often really bewildered by the patient's behavior, and they find it really hard to communicate because the patient often misinterprets comments. And what I mean by this is you might have a daughter who refuses to eat, and the mom might say, why aren't you eating? I cook this good food just for you, and you won't eat it. And the mom is coming at this from, I'm worried about you, and I know you're getting sicker, and nothing I'm trying is working. And what the daughter is hearing is just criticism over how she eats her meals. So there's a lot of family dynamics and working on how family members communicate between each other. And then a lot of education for the client and the family also on the nature of illness, the symptoms of anorexia nervosa and bulimia nervosa, what constitutes obesity, what are the causes of eating disorders, what are the effects of the illness of anorexia and bulimia and obesity on the body. And then also the management of their illnesses. You want to go over the principle of nutrition. What is good nutrition? What is portion control? Want to explore other ways the client may feel in control of their life. The importance of expressing fears and feelings rather than holding them inside and having them emerge as anorexia or bulimia. And also develop alternative coping strategies. Let's see, indications and side effects of prescribed medications, relaxation techniques, problem-solving skills, and then support services. There's Weight Watchers International over on Overeaters Anonymous, the National Association of Anorexia Nervosa and Associated Disorders, and then the National Eating Disorders Association. So evaluation of the client with an eating disorder requires reassessment of the behaviors. And eating disorders can be very, very difficult to treat. And oftentimes it's a lifelong situation that the person and their medical team is continuously monitoring. So it's not like when you break a bone and the bone knits and then you go on your way. Managing and dealing with an eating disorder oftentimes is a lifelong situation. And then you want to evaluate the behavioral changes that are required by the client and family member, and were they able to do those changes. Now the treatment modalities, there's a bunch of different treatment modalities. There's behavior modification, and with these behavior modification, issues of control are central to the etiologies of these disorders. For the program to be successful, the client has to perceive that he or she is in control of the treatment. Successes have been observed when the client is allowed to contract for privileges based on weight gain. So if you, for instance, if the client gains 5 pounds, they get certain privileges. If the success is also correlated to whether or not the client has input into the plan of care, clearly sees what treatment choices are, if the client has control over their eating, the amount of exercise pursued, and whether or not to induce vomiting. So, and basically for this type of behavioral modification to work, we're not saying that like if the client has control over the amount of exercise, we're not saying, okay, you can go and exercise 8 hours. What we do is we care plan it for, okay, on Monday you can exercise a half hour or an hour, or you can lift weights, or on the next day you can do cardio, or make them able to have choices over their exercise plan, but not in a way that's going to be harmful to them. Now the staff, in order for this to work, for this behavior modification to work, the staff and client need to agree about the goals and also about the system of rewards. And the client has a choice to either abide by the contract and gain weight and then earn the desired privilege. Now with individual therapy, this can be helpful when the underlying psychological problems are contributing to the maladaptive behavior. Family therapy involves educating the family about the disorder, assessing the family's impact on maintaining the disorder, and then assisted methods to promote adaptive functioning by the client. Psychopharmacology, no medications are specifically indicated for eating disorders. Various medications have been prescribed for associated disorders such as anxiety or depression. And medications that have been tried with some success include, for anorexia nervosa, Prozac, Zyprexa. They've had some success with some people who have anorexia. With bulimia, Prozac and Elavil and Nardil have been helpful with some of them. For binge eating disorder with obesity, Topamax has shown some success, again, with some people. But for other people, the medications just simply don't work.